age, sex, use of a hypertensive drug, even if you're not hypertensive at the time, the presence of a previous MI, previous stroke for sure. But right in the middle is BMI. And for each increase by 5, you have a rise in risk of about 2 to 0.5 increased risk. So your risk is 1.25 or 1/2 more than those who are not. The slides are not moving. Can you help me? You also have the risk of progressing from paroxysmal atrial fibrillation to persistent atrial fibrillation. And the same thing, the same gradation between BMI and the higher the BMI, the more likely the AFib will change in character from paroxysmal to persistent. What if you looked at the interaction with left atrial volume? Because this was one of the objections to the other study I showed you from the Framingham. If you try to interact with left atrial volume, which increases with obesity. So did they develop the atrial fibrillation because they're obese, or is it only because the left atrium got enlarged? In this case, regardless of whether your left atrial volume was higher or lower, you still were likely to progress with your atrial fibrillation. So obesity contributes to the incidence and progression of atrial fibrillation based on what we have shown. And there are correlates. So this is a slide that shows how the P-wave duration changes with increasing obesity. And whether you're Caucasian or African American, which are two groups, you can see the increase in the P-wave duration on the y-axis in accordance with the waist circumference. And then there are a lot of theories and possibilities as how this could happen. Clearly, obesity is related to obstructive sleep apnea, and we talked about that, and I will be talking about obstructive sleep apnea as well. But also, obesity, the fat that you see under the skin is also happening around the heart and within the heart, around the muscles. Obesity is related to inflammation. The ventricle has to work harder, ends up being stiffer, and there being more diastolic dysfunction. Coronary artery disease is another association that could be contributing. And the increased association with metabolic syndrome, which has hypertension, diabetes, and lipid dysmetabolism. So all of these things will be contributing to obesity. So nice to know, but what can I do about it? Does it make a difference on the patients you're seeing? Now, this is one early study that looked at these symptoms and severity of the symptoms. The burden, how much symptoms you're having, and how impactful they are on your life. In other words, you're having symptoms a lot of times in the day or a lot of times in the month, and also, are they disabling to you in your normal daily activity? And this came out of Adelaide, Australia. It's a very well-reputed group. And and in this slide, you can clearly see that they succeed in losing weight and in reducing the waist circumference. And more importantly, they are significantly successful in reducing both severity and duration of their symptoms, burden and severity. And this separation happens early. By 3 months, you already have a significant difference, and it is sustainable. You can continue for a year and more, even though patients may not be able to sustain the same level of rigorous diet and exercise. So the bottom line is, it's a worthwhile investment, all right, to try to talk to your patient about listening. I will move fast, and I see time has moved ahead of me, but what is it about sleep and breathing? I was quite interested in this sleep and breathing story. My colleagues in the sleep apnea, the sleep specialists, engaged me in a couple of studies, and it's very fascinating. So I was able to suck up some slides from time long gone, but I will tell you one thing, that when you read the literature, you have to be careful. There's a lot of nomenclature that gets overlapped. So First of all, there's obstructive and central sleep apnea. We'll talk about that. But obstructive is the most common. They tend to overlap. And so people say, well, it's sleep disordered breathing. But then you don't always know that the sleep caused the disordered breathing. So it's sleep-related breathing disorders. And so that's the in word now. So that's what you're going to use. But some of these slides go back to a time when we were just saying obstructive sleep apnea. So to begin with, this is largely underdiagnosed. Most people are not aware that they're not breathing well during sleep. Up to 25% of men and 10% of women may have some form of sleep disordered breathing. That it may be possible that we know more about it, and indeed now they don't do as many in-house, in-hospital sleep studies. They have these portable things you can take home with you, at least for screening, with 1 channel or 2 channels. And then of course, if you look at certain people, you'll have more and more evidence of sleep disordered breathing. So this is an example of an obstructive sleep apnea. I'll show you the highlights because for me as a cardiologist looking at this stuff, it was very intimidating. So to start with, this is the channel with the airflow. And right there, you're seeing that the airflow has slowed down. So you had the oscillation of the breathing here, and then it comes to a stop. Now, the next item is following this period of apnea. So it lasts more than 10 seconds to meet the definition of apnea. And then after it, in the brain EEG, you'll see arousal, right? So this is, they wake up because now the hypoxia causes them to drop. And this is accompanied by increased activity on the EMG as well, which is the muscles. So now what is this arrow showing? The arrow is showing the hypoxia that happens. And also important for you to look at now is what this last box is showing is that the abdominal muscles and the thoracic muscles are working, and they're working opposite each other ideally. So this is an obstructive apnea episode with an arousal. So this cannot be healthy for you, that you're going through repeated episodes of these. To meet the diagnosis, you have to be like at greater than 15 per hour. Stress hormones, and clearly there's evidence of inflammation and free radical injury production. These are studies showing you the sympathetic nerve activity as measured from a peripheral nerve. Patients who are going through an obstructive sleep apnea have a heightened level of sympathetic discharge. Blood pressure is also elevated and fluctuating, especially during the night. Then, if you give them CPAP, this sympathetic activity decreases. CPAP is continuous positive airway pressure, which is the treatment. But the point to remember is that these patients, even though this is happening at night, even during the daytime, they have a high level of sympathetic discharge. They're conditioned to be on overdrive. Okay? And this is saying the same thing, actually. Also, there's evidence of inflammatory markers, as you can see, CRP. And so, in fact, sleep apnea is a problem, and it's in the middle of everything. It's associated with pulmonary hypertension, with stroke, bradycardia, different kinds of arrhythmias, including AFib, which is what we're talking about, sudden death, acute coronary syndrome, hypertension, and heart failure. I will skip through the next few slides because it just shows the increased incidence of hypertension, and this is from a large cohort from Toronto, with the increasing level of AHI. And as you can see, if it's less than 10, which is mild, if it's between 5 and 15, it's mild. And so as it goes up, there is more and more likelihood that you will have hypertension as a diagnosis. And the same thing will happen with heart failure. I will just add a word of caution, is that the problem is the hypertension will improve when you use CPAP with people with sleep disordered breathing. The problem is heart failure has been a problem. Trying to give CPAP has not shown a lot of improvement in heart failure. But how about for our topic? Again, is this information actionable? Does it help to know that somebody has sleep apnea? And this is a very illustrative study. This was first shown by the Mayo group. They treated people coming for a cardioversion. They screened them first, and if they had AFib, they treated them. In this case, this is after ablation. And so they have a lot of, this is a retrospective analysis of a registry. So after the fact, they went back and said, well, who of these people had sleep apnea and who did not? And so they found that they had 62 patients who have sleep apnea based on a sleep study. So, well, was everybody taking CPAP? Well, lucky for them, about half of them were and half of them were not. So this is the main part of their study, showing these two boxes. The other two are control groups. They had some patients who do not have sleep apnea, all right, and patients who received ablation, right? But these are then compared to people who had sleep apnea but did not get an ablation, even though they were on CPAP. So it's a double control in a certain sense. It's intuitive to know that the blue line is the people who do not have sleep apnea. After the PVI, this is their freedom from AFib. So they did pretty well after the ablation, after a pulmonary vein isolation. But interestingly, in red is people who had sleep apnea but were treated. They're almost as good. The ones who are not as good are either those who have sleep apnea, who did not get an ablation, or who did not get CPAP. And those two are equally bad. So what do you conclude? You conclude that, A, just because you have obstructive sleep apnea and ROBs, you still can be offered an ablation and you'll get benefit if you use the CPAP at the same time. Secondly, that if you are going to do an ablation, make sure they do the CPAP so you get the most benefit out of both, right? And in summary, to conclude this talk, and I appreciate your patience, these are models, their dietary habits. You can treat their sleep apnea, and I appreciate you inviting me and listening. Thank you very much.
شكرا دكتور علاء على هذه المحاضرة